moving towards session 2. We are running short of time, so moving towards session 2. For session 2, I would like to call upon chairpersons Dr. Anshul Mittal sir, Dr. A.K. Sharma sir, Dr. M.K. Srivastava sir, and Dr. Monica Gupta ma'am to please come on the dais. एक chair और एक चेयर उधर और लगा दो ना, 4 लोग बैठेंगे. Now over to our chairperson for session 2.
गुड इवनिंग एवरीबॉडी. अभी हम लोगों ने बहुत हाई टेक्नोलॉजी डॉक्टर स्वप्निल और डॉक्टर अंशुल से सुना और हम लोगों को जानकारी हुई कि इस तरह की चीज़ें हैं बनारस शहर में तो होती नहीं हैं. तो हमें उम्मीद है कि बनारस में भी डॉक्टर स्वप्निल आएंगे तो ये शुरू करेंगे और हमको ये पता तो लगे कम से कम क्या हो रहा है. पहले हमें याद है कि अपने टाइम में हम लोग करते क्या थे कि 3 महीने का ट्रायल दे देते थे एटीटी का और उसको फीवर कम हो जाता था तो वो सोचते थे भाई ये टीबी है और नहीं तो फिर कुछ दूसरा है. और ये मुझे याद है अच्छी तरह से कि हमारे एक डायरेक्टर हुआ करते थे IMS के, उनको 9 महीने तक टीबी का इलाज चलता रहा और फ़ायदा नहीं हुआ. अंत में डायग्नोसिस सार्कोइडोसिस की बनी. तो इस तरह की लेटेस्ट टेक्निक जो आई है इससे डेफिनेटली बहुत फ़ायदा होगा. एंड आई कंग्रेचुलेट डॉक्टर अंशुल एंड डॉक्टर स्वप्निल बोथ ऑफ द पर्सन्स. अब द नेक्स्ट टॉपिक इज़ वेरी प्रैक्टिकल टॉपिक, दैट इज़ डिस्निया. एंड आई एम श्योर एवरी फिजिशियन, एवरी सर्जन फेसेस दिस प्रॉब्लम. अभी आई एम श्योर डॉक्टर पाठक इज़ हियर एंड ही विल जस्टिफाई द टॉपिक. देयर आर सो मेनी कॉजेज ऑफ डिस्निया like lung disease, tuberculosis, complications of tuberculosis, bronchial asthma, heart disease, renal failure, anemia, and etc. etc. So learned Dr. S.K. Pathak is definitely justify this, and I'm sure the audience must be benefited a lot. And Dr. Pathak is very long his introduction. But the main introduction is Dr. Pathak is MBBS from GSVM Medical College and he has done his DCH also and after that he did his MD chest under Dr. Rajendra Prasad Saab and he is sitting over here. तो चेला और गुरु दोनों सामने, इससे ज़्यादा इंट्रोडक्शन की कोई ज़रूरत नहीं है और टाइम कम है. प्लीज़ ओवर टू डॉक्टर पाठक.
Thank you, sir. Thank you all audience and respected chairpersons. Today the topic is for general practitioner medical emergency in dyspnea management, how we can go for that. The topic well known and every doctor facing this problem in this clinic, in hospital or in neighbors. So we have to know well about this. First of all, I welcome all of you on behalf of Respiratory Conclave Conference 2023. So thank you for coming for this conference. As a topic, everyone know that SOB, a shortness of common symptoms in general practitioner. Diagnosis can be challenging as it appears in the multiple disorders, most commonly respiratory or cardiac. Underlying disorder can range from the relatively simple to serious condition, and timely management, diagnosis and initiation of appropriate therapy is required as initial purpose, and family physician, especially general physician, should be equipped with manage the stabilize the patients. So there are many family physicians working their clinic and hospital. They have to know about this. So what the etiology about the breathlessness? There the be divided in many groups and symptom-wise and one set of disease. Etiology can be at acute breathlessness. It can be divided in acute and chronic. The most common cause of the acute breathlessness are the pneumonia, acute chronic bronchitis, congestive heart failure, pneumothorax, hyperventilation syndrome, foreign body aspiration, diabetic ketoacidosis, or other metabolic disorders. As a chronic breathlessness, this is the more common if the common cardiac respiratory causes are ruled out as considered. Anemia, one is the important, and hypothermia and obesity, chest wall pathology, and neuromuscular diseases. These are also the common causes for the chronic breathlessness. So we can divide in many acute and chronic. Here, as a causes of breathlessness grouped by the speed of onset. It is very important. How times dyspnea and what time dyspnea presented to the patient. This is very important, as the dyspnea may present the instantaneous onset as a pneumothorax and pulmonary embolism. Patient came to a clinic or hospital with a short history of the 1 hour, 2 hours. We have to suspect this may be the cause, pneumothorax or pulmonary embolism, where the acute minutes, hours. The patients come with hours, 10 hours, 10 hours, 8 hours. We have to suspect that COPD, the parenchymal disease, pneumonia, pulmonary edema, and pulmonary hemorrhage, pulmonary vascular diseases, and cardiac diseases like acute myocardial infarction, arrhythmia, valvular heart diseases, and metabolic acidosis and hyperventilation syndrome. As a subacute days, patient comes with history of the 1 to 2 days, 3 days, 1 weeks. We have to suspect that other above the causes, it may be the pleural effusion, lower collapse, and acute interstitial pneumonia, and superior vena cava obstruction, pulmonary vasculitis. For the chronic month to year, if patients come with history of 1 year, 2 year, 1 saal, 2 saal se patients are, we have to suspect that same above and plus. COPD is one of the most common cause. The diffuse parenchymal disease like ILDs, and pulmonary vascular disease like chronic thromboembolic diseases, and pulmonary hypertension, and hyperventilation syndrome, chest wall deformities. It may be the thyrotoxicity is one of the important causes in the chronic onset of dyspnea. The causes of breathlessness with normal X-ray. First, we have to advise to rule out the cause of dyspnea. The X-ray is very important tools. So we have to segregate and breathlessness with normal X-ray. The normal X-ray present with dyspnea is the acute disease like asthma, upper respiratory obstruction, bronchiolitis, and pulmonary vascular diseases. Early parenchymal disease like sarcoidosis and pulmonary diseases, and cardiac disease like angina, arrhythmia may present with normal X-rays, and neuromuscular vasculitis, metabolic acidosis, anemia, and thyrotoxicity, hyperventilation. These patients may present a normal X-ray. The cause of episodic and intermittent breathlessness. Patient may present with episodic and intermittent. The asthma is one of the important causes, and pulmonary edema, and angina, pulmonary embolism, and hypersensitivity, pneumonitis, vasculitis, hyperventilation syndrome. Anxiety is one of the important causes for dyspnea if you rule out all other pathological causes. As a breathing pattern, these are for the PG students, how we define the tachypnea and bradypnea and orthopnea. And the PG student must know about this terminology. As a SOB grading, everybody knows that how we can grade the SOB, the 0, 1, 2, 3, 4, 5. The pathology, as we know that it may be the controlled ventilation where the cyclogenic factors may affect the respiratory center medulla response, where the biochemical changes like pH, PaCO2, and PO2 level, vascular pathology, and chest wall that send a trigger to the motor, muscles, motors, and chest wall, and hyperventilation. So after the stimulation from the medulla, every muscles and parts of lungs working as a hyperventilation and dyspneic presentation. History is very important for every diagnosis. So we have to take history as a complete history. The complete history is maybe the history of the cardiac or pulmonary problem, and determine the onset, duration, and occurrence of the rest exertion. Cough may present in asthma. Pneumonia and cough with change of characters of sputum may due to the acute exacerbation. Epiglottis should be the history of case of the sore throat in the children. Fever is often associated with pneumonia and croup or bronchitis. So history must be seriously. The chest pain may be the cardiac pleuritis and musculoskeletal. Pleuritic chest pain may be due to the pericarditis, pneumonia, pneumothorax, pulmonary embolism, and due to the pneumothorax. Severe shortness of breath may be 1 to 2 hours suggestive of congestive heart failure. Consider non-respiratory causes like anemia, acidosis, truck. कुछ दिन पहले मेरे पास क्लिनिक में पेशेंट आया था और सांस लेने की प्रॉब्लम लेके आया और फिजिशियन को संपर्क किया, जनरल प्रैक्टिशनर को, और सभी ने उसकी अस्थमा की डायग्नोसिस बना के ट्रीटमेंट्स होगा, जबकि उसका जब हमने हेमोग्लोबिन सीबीसी इज द वेरी इंपॉर्टेंट रूल, हेमोग्लोबिन वाज ओनली 3 ग्राम, आफ्टर ब्लीडिंग पेशेंट वाज ऑलराइट. तो आप सीबीसी इज वन सिंपल टूल्स वी कैन डायग्नोज एज सीवियर ब्रेथलेस, इट मे बी कॉज ऑफ द एनीमिया. So severe shortness of breath 1 to 2 hours, congestive heart failure. The anginal chest pain shortness will suggest you of the myocardial infarction. The inquired about the dysphagia, maybe the include of GRD is one about important things as a patient of history of गैस की प्रॉब्लम है, मुझे कच्ची डकारें आती है, उल्टी जैसा लगता है, ये this may aspirate to the lungs and may micro pneumonia and micropneumonitis that cause the breathlessness. Anxiety symptoms may simply a psychogenic causes, adverse effect like beta blockers. As we are not preferring a beta blocker generally as a chest physician, the cardiologist generally use the beta blocker, but safest beta blocker must be used for the patient if patient is a heart disease. History of orthopnea, pedalema, and PND is suggestive of the congestive heart failure. So sputum is very important to rule out the cause of the dyspnea. White mucoid sputum evident of asthma, chronic bronchitis, where the purulent green yellow sputum may indicate the respiratory infection, where the blood can be indication of the carcinoma of the lungs or the pulmonary tuberculosis or pulmonary embolism. Prothy white or pink sputum evident of pulmonary edema. Thick viscous sputum is feature of severe life-threatening asthma. Foul smelling sputum is an indication of the respiratory tract infection. As a physical examination is very important after history, we have to examine the thoroughly every part of the body, but we must the respiratory system, the gauge of the severity. The pulsus pulmonale may present in asthma, COPD with cardiac component. Starter may indicate the upper respiratory obstruction. But the JBD may be present in the carpulmonum caused by the severe COPD, congestive heart failure or cardiac component. Also check a thyroid, check whether the trachea is central or auscultation or stridor. The physical examination, cardiac and pulmonary, palpate the chest for subcutaneous emphysema and crepitus and percussion of the dullness in the indication for the consolidation or effusion. Hypertension suggestive of the pneumothorax or bullous emphysema. As auscultate the heart, lungs for murmur, for extra heart sound, absent of breath sound, maybe the pneumothorax is very important. Patient present with dyspnea, you have to not put the stethoscope on the chest. You can't know the diagnosis, what the exactly. As physical exam, wheezing sound may be present due to obstructive lung diseases, where the rapid irregular heart rate may be the signify the dysrhythmia and S3 gallop and suggestive of LV dysfunction and congestive heart failure. The loud P2 may be the sign of the pulmonary hypertension, PST, or the cardiac pulmonary. As a murmur may be the indirect indication of congestive cardiac failure, and the distant heart sound may be the present in the cardiac component. Abdominal examination look for the hepatomegaly or ascites, as especially in case of the COPD, hepatomegaly may be observed. Where the extremities are the assessed for the edema, sign as a pedal edema, TPT, and discs are the examined by the clubbing and cyanosis. Very important tools to examine the patient. Clubbing, there are many causes for the clubbing. It may be the ILD, it may be the CA lungs, and many other things. We have to, bronchitis is the clubbing causes. We have to examine the clubbing. Patient को finger के nails को देखना से patient को कुछ समझ में आया ना, लेकिन आपको बहुत कुछ समझ में आ सकता है. As a diagnosis workup, pulse oximetry is one of the important tools. Initial diagnosis, radiographs are the obtained the pneumonia, as a especially COPD, pulmonary edema, and congestive heart failure. So ECG must be done for the patient of dyspnea, myocardial infarction to rule out the anginal pain and anginal dyspnea. The D-dimer can be testing for the pulmonary embolism is the important tools for diagnose the patient of pulmonary embolism. For the clinical investigation, we have to order for the sputum examination. The appearance, microscopic culture and sensitivity and cytology, radiology, chest X-ray and tomography, and radioisotopy scanning, bronchoscopy, lung function testing, pulse oximetry, ABG, 12 leads ECG and lung biopsy. These are the investigation to rule out the differentiate the different kind of the dyspnea. For the initial assessment, we have to management for the patient, the initial airways patency, to listen the lungs and observe the breathing pattern, including use the accessory muscles and monitor the cardiac rhythm, where the measure the vital signs and pulse oximeter, obtain any history of the cardiac pulmonary disease or a trauma, evaluate the mental status of the patients during the examination. Where the further assessment is required, once the patient in the emergency department, you have to exclude out the history of the obtain the determine the level of acuity and airways mental status and ability of the speak the breathing efforts in the assess. History about the medication use, cough, fever, chest pain, duration of breathlessness and underlying cardiac pulmonary disease is elicited. The physical examination done by the checking vital signs, listening of the breath sound, observing the skin color as patient is sinus or appeal or everything. Recognition of the management of unstable patient, the patient, this patient present with symptoms like the hypertension, altered sensorium, hypoxia, unstable arrhythmia, stridor, tracheal deviation and inhalator breath sound, respectively at more than 40. First administer the oxygen and consider the intubation if needed, urgent, need establish the IV, assess and start the IV fluids and oxygen and perform the needle thoracocentricity. Patient is at the is a pneumothorax. We have to put a needle to relieve the patient in the case of the tension pneumothorax. Administer the nebulization solution if patient has the history of COPD or asthma. Transfer the patient to an emergency department with trained health care worker to save the patient life. As a clinical presentation and trials, the patient present with either of the breathlessness or tachypnea. The trials begins with the determine the degree of urgency and the severity of symptoms. The following telephone trials may be utilized during the management of the patient. The oxygen therapy, as we have to start as oxygen indication of oxygen is the cardiac respiratory arrest and hypotension, shock and respiratory distress, anginal and anaphylaxis. With the method of oxygen therapy is a nasal cannula, face mask or venturi mask with the oxygen delivery system, oxygen supply with oxygen cylinder, black color with white top and with top flow meters, oxygen tubing and delivery of the device humidifier is must for the patient who are the required more than 2 or 3 liters oxygen. As oxygen concentration with oxygen flow, we have to FI2 level for the 40% of the 6 to 10 liter and 32% 4 to 6 liter and 2 to 4 liters is 28%. So when we are utilize the patient for the oxygenation, we have to just suspect that what kind of the oxygen we are going the patient giving. Where the humidification is recommended, the patient is more than 4 liters oxygen required. Where the oxygen toxicity is observed in some cases, especially in case of COPD, we have to avoid high oxygen for the surfactant in ARDS. And in COPD, as a CO2 narcosis, we have to not use the maximum oxygen. We have to use only the level of 90 to 94, 95, not more than 100%. Okay. And in your retrolental fibrolysis is observed, the patient is use the high flow oxygen, high level oxygen. As a differential diagnosis in children, many pediatrics using the most common cause to include the acute asthma, pulmonary infection, upper airway obstruction, some associated condition like epiglottis, crop, and myocarditis, asthma, and diabetic ketoacidosis. It may be the fatal to the children. Always consider the foreign body aspiration in case of the special for the children's croup and bronchiolitis may be caused by some respiratory infections. As a summary, respiratory difficulty is the common presenting symptoms in the general practitioner. Initial role of the GP is the assist to severity and respect of the need for the oxygen intubation, and unstable patients often require intravenous assist oxygenation or possibly the intubation by ventilatory support. The cause of the discuss of the acute or chronic or commonly respiratory cardiac. In a stable patient, the underlying cause are determined after the proper diagnosis or evaluation of shown. The management depends upon the etiology. This is after oxygen, we have to use the BiPAP. This is a long lecture about the BiPAP. But we have to use if patient not maintaining the oxygen with normal oxygen cylinder or consider normal oxygen tubing. This is the second step. When patient failure to the BiPAP, we have to go for the ventilator support. The very important tools to save the life. So we have recommend if patient is not responding with BiPAP or normal oxygen, we have to intubate patient as urgent and get the ventilator proper. This is the long lecture, the ventilator support, how we can. Due to short time, we have to just close this lecture here. Now, thank you so much for everyone. Thank you.
Very good lecture, Dr. Pathak. Congratulations. This happens to be the bread and butter for most of us sitting here. So I think his deliverance was perfect. I wonder if anybody has any questions. If there are no questions, there is one thing I want to add, that for us physicians, even BNP we use as one of the markers, one of the quick markers to assess the respiratory, dyspnea cause. Dr. Ajay Pandey is there, he will tell us. Boss, I'm sure you will agree with me that BNP is one of the markers to assess the reason for breathlessness.
I think we have a separate session after this. Dr. Pathak has already planned a very good case discussion regarding that. But I agree with you that, biomarkers are now very important tool nowadays. And they are, point of care devices now, which we can use in our emergency medicine as well. Anybody presenting to you in an emergency department with dyspnea, we can very well differentiate between a cardiac dyspnea and a respiratory dyspnea with the help of BNP and other cardiac markers. We have one case presentation, Dr. Sakshi is presenting in the upcoming sessions. We will have a great discussion during that time. But I do agree that these, BNP, anti-pro-BNP and cardiac panel markers like troponins and CKMB, they all act as a very good tool for rapid diagnosis of cardiac versus respiratory dyspneas.
Say something?
Thank you. So, any questions from the chairperson? If I think my lecture
Dr.
was
Pathak,
very
you
short.
answered everybody's queries actually. You were very good in your lecture. And I must congratulate you to look at the crowd. Wonderful. You've really put in a lot of effort. Congratulations.
Thank you, sir.
Yeah.
Thank you. Thank you, sir. Thank you. Thank you. Thank you.
So thank you very much, sir. Now I would like to call upon Dr. Deepak Kalra, sir, to present memento to our speaker, Dr. S.K. Pathak, sir. Dr. Swapnil, be ready for that. Chairperson. Thank you very much. Thank you, sir. Now I would like to call upon Dr. Swapnil Pathak to present bouquet and memento to Dr. Anshul Mittal, sir. Chair. Now to Dr. A.K. Sharma, sir. Now to have Dr. M.K. Srivastava, sir. Now, I would like to call Dr. Sakshi to present memento and bouquet Angavastram to Dr. Monica Gupta, ma'am. Thank you, honorable faculty.